All right. Good afternoon, everyone. My name is Courtney Shaler. I manage the Adirondack Rural Health Network for AHI. We want to let you know you're going to be getting an email from us. GoToWebinar is fantastic. We love it. It did let us register up to 1,000 people. We hit 170. Unfortunately, it's now telling us only 101 people can sign in. We are going to be emailing out the transcript of the webinar directly after to everyone. We also will be putting it up on our YouTube channel and on the North Country Telehealth Partnership website. So we're going to get it out there to everyone, and we apologize for this last-minute inconvenience. We're going to make sure we get that taken care of before our next webinar in 2 weeks. I'm going to introduce Katie, our presenter now. Welcome to the 101 webinar. I'm going to introduce Katie Cook, our telehealth program coordinator here at AHI. Katie has been with AHI since November of 2016 and has helped grow the telehealth initiative in the North Country alongside with Fort Drum Regional Health Planning Organization to over 40-plus active programs. She is a researcher to the region in all facets of telehealth and telemedicine, from keeping up on regulatory and reimbursement issues to program planning and infrastructure. Today, she will be speaking about telehealth from an introductory perspective, answering frequently asked questions she hears in the field, and also dispelling some commonly heard myths that she hears on the topic. We will be taking questions after the webinar. I'm going to turn it over to Katie now.
Thank you, Courtney. Good afternoon, everybody. My name is Katie Cook, and most of you on this recording know me. So again, apologize about the GoToWebinar issue. We haven't hit our max yet, but again, I will be sending this out. So just some housekeeping items to get started today. As we mentioned, this webinar will be recorded for future access, and the links will be sent out later this week. We are going to make this available on LMS for our district partners, and we will also be archiving it on the North Country Telehealth Partnership and AHI websites for access. We are going to take questions throughout the session. Please submit any questions that you have through the Q&A box on your GoToWebinar dashboard. All of the questions will be answered at the end of the webinar. So please make sure you submit those through the Q&A dashboard and not the chat box. The next webinar will be on Tuesday, February 13th, and that's where we will be discussing billing and reimbursement. Just a quick disclaimer, Adirondack Health Institute has made every attempt to ensure the accuracy and reliability of the information provided today, but the information is provided as is without warranty of any kind. AHI does not accept any responsibility or liability for the accuracy, content, completeness, legality, or reliability of the information contained in this webinar. To get started, I wanted to do a quick poll with everybody. So I'm going to bring that up. This poll talks about which of the following areas best describes your primary role at your organization. So please take a minute to complete this poll. All right, I'll just give a few more seconds for folks to complete the poll. All right, so I'm going to close the poll now. It looks like most of you on the line are in an administrative or executive role or program or project manager role, which is really exciting. This is certainly the target audience that we look for when implementing telehealth programs. So let's get started today. Telehealth versus telemedicine. I want to level set with everybody that's on this call. I know many of you may already know the definitions of telehealth versus telemedicine, but I think this is a good starting point. So New York State defines telehealth and telemedicine differently. If you ask the American Telemedicine Association, they do not define them differently. So it really depends on what school of thought, state, or organization you come from. Telehealth and telemedicine are often used interchangeably, but in New York State, telehealth is the overarching definition that encompasses your live audio video, your store and forward, your remote patient monitoring, mobile health, etc. New York State then goes on to more narrowly define telemedicine as the specific two-way live audio video communication. Some other important definitions are hub and spoke. So think of a bicycle wheel. Here we have our bicycle wheel, and at the center we have our hub site. That's where the provider is often located. Think of a regional hospital, academic medical center. And then you have your patients at the spoke site. Those spoke sites could be different primary care offices that are affiliated with a hospital, maybe a mental health clinic. So always think back to that hub and spoke model and think of a bicycle wheel when planning out your telehealth initiatives. The most common types of telehealth delivery are, of course, your two-way live audio video or synchronous communication. This is the most common modality that telehealth is offered through. You'll often see this in primary care, behavioral health, or stroke care for TPA administration. Next, we have store and forward or asynchronous communication. This is the transfer of data from one site to another through the use of a device that records an image and is sent off for consultation. This is commonly used for radiology, dermatology, and ophthalmology. So think of diabetic retinopathy screening. And lastly, we have remote patient monitoring. This is monitoring of patients outside of traditional clinical settings and the daily monitoring of vitals in a patient's home. A great example of this being done in the region is through Adirondack Health in Saranac Lake. They have been instrumental in deploying remote patient monitoring technology to public health departments and home care agencies to ensure that our rural residents who have maybe multiple chronic conditions can be monitored in their home. And it helps to avoid ED readmissions, which is obviously a huge component of DSRIP, which many of us on the line are familiar with. Some less common types of telehealth delivery. So mobile health, or mHealth for short, is it's a growing component of telehealth. It's becoming more and more popular over the last several years. And mHealth is using a health-based smartphone app or wearable device to track your own health data or access a provider in your state via an app such as some common ones are Teledoc, Doctor on Demand, MD Live. This is used primarily for triage and low acuity issues. So of course, if you were in a crisis situation, you wouldn't utilize this type of service. And lastly, we have provider-to-provider consults. While this may not fall nicely under the telehealth definition, the Project ECHO model is a great example of a provider-to-provider consult. Project ECHO stands for Extension of Community Health Outcomes, and it's a way to get basically primary care providers the education they need on certain subspecialties. It started back in 2003 in New Mexico as a way to provide education on hepatitis C and HIV to primary care providers in the state, and has since grown to a global initiative. So why is it important to utilize telehealth? First and foremost, it's increasing access for your patients. So telehealth allows providers to meet patients face-to-face using that video conferencing technology to have discussions and provide treatment, whether that be follow-up or the first time they're being seen. In addition to increasing access, the store and forward technology is very important. In the rural areas that we all work and live in, a great example is dermatology. It can often take months to get in to see a dermatologist. So if a practice was to implement teledermatology, you can provide your patients access to those specialists far sooner than if they were to call the dermatologist office themselves and get that appointment. Next up, telehealth is important because it allows you to monitor your patients or even your loved one's health and behaviors remotely, which improves their health outcomes and keeps them out of the emergency room. And lastly, of course, while not necessarily telehealth, educating providers through video conferencing improves provider satisfaction and also improves patient outcomes because those providers have obtained additional education or guidance on difficult cases. So now we're going to get into some frequently asked questions. This section is comprised of questions that I've heard over the last year and a half of my experience with telehealth. These are the frequently asked questions that I hear from providers, from executives at hospitals or health centers, and I've kind of grouped them all together to really hit the most important points. So first and foremost, is telehealth/telemedicine safe? I use those terms interchangeably, so that's why they're both listed. So the answer is absolutely. Both state and federal agencies have established comprehensive guidelines regarding the safety and comfort of the patient, the provider, and the facility. These guidelines are often stringent and they require secure hardware and software for telehealth purposes. Telehealth actually does keep patients safer. There have been several studies showing that medication errors can be significantly reduced by telemedicine and detect treatment-related adverse events. A 2013 study done in the Annals of Internal Medicine found that telemedicine may reduce errors in rural emergency departments as well. Researchers from various campuses of the University of California found that rural ER doctors made errors in administering medication only 3% of the time when they took part in a telemedicine consult versus 12.5% for patients having no consult. Secondly, there was a study done within the integrated delivery system of the San Francisco Department of Public Health, which found that ambulatory patients with diabetes who had a weekly interactive phone call that provided not only patient education, but self-management support, followed up with targeted nurse support, detected 59% more treatment-related adverse events than patient detection alone, which was 11%. Next, is telehealth private and secure? Yes, so long as your facility and the provider are utilizing a HIPAA-compliant encrypted platform designed for this very use with a business associate agreement in place, then you are good to go. Popular platforms for telehealth include Zoom, Cisco, and Video. There are far more than just those three, of course. And just keep in mind that consumer applications such as FaceTime or Skype are not secure enough for video visits. Is telehealth technology difficult to use? Only if you make it. Of course, it depends on the specific situation or application, but providers and patients who have a basic familiarity with online applications should be able to quickly figure out how to use a telehealth application. Of course, practices and hospitals should be more concerned with the user end and not the technology side. There are experts that can handle that. Next, does Medicare or Medicaid pay for telemedicine? I, of course, will be discussing this further on the next session on February 13th, but I wanted to touch on this today. So Medicare, traditional fee-for-service beneficiaries living in rural areas will be covered when using telemedicine for video conferencing or remote patient monitoring. Store and Forward is not currently covered. For Medicaid, it depends on the state, and every state plan is different. New York State specifically has fairly comprehensive telehealth coverage. Some of you may have heard that New York State Medicaid managed care plans are adding in lieu of services through telehealth innovation plans. The Department of Health recently encouraged these managed care plans to make telehealth services available to close gaps in coverage. And these cost-effective alternative services are often referred to as in lieu of services. Mainstream managed care plans were asked to submit a telehealth innovation plan to the New York State Department of Health by December 1st. An example plan could include an eligible originating site such as the patient's home. The Department of Health is currently reviewing those requests and will be soon announcing which plans will offer telehealth services in the coming weeks or months. Do private insurers cover telehealth or telemedicine services? Yes and no. 34 states and the District of Columbia require that private insurers cover telehealth the same as they cover in-person services. It, of course, varies by payer. Many of the payers in upstate New York cover telehealth or telemedicine in some capacity. So if you look at this map, the orange states are states that have enacted the telemedicine parity law. The blue states do not have any parity activity at this time, and there are a few that have partial parity or proposed parity. So as a whole, we are moving in a positive direction. Of course, again, reimbursement will be covered further in the next session on February 13th. So now you're probably asking, what's the difference between coverage parity and payment parity? Coverage parity laws, which New York State has, require health plans to cover services provided via telehealth to the same extent the plan already covers the services if provided through an in-person visit. Payment parity, on the other hand, requires health plans to pay providers for telehealth services at the same or equivalent rate the health plan pays the provider when the service is done in person. What we really need is payment parity, and many states have made attempts to enact payment or reimbursement parity, but have received significant pushback from private payers who want to be able to set their own rates. We'll talk more about this at the next webinar. Can medications be prescribed via telehealth? Yes, subject to state and federal guidelines, medications can be prescribed over video conferencing technology. In 2008, the Ryan Haidt Online Pharmacy Consumer Protection Act was passed by Congress, which prohibits dispensing controlled substances via the internet without a valid prescription. For a prescription to be valid under this act, it must be issued for a legitimate medical purpose in the usual course of professional practice, meaning that with limited exceptions, a provider must conduct at least one medical evaluation of the patient, either in person or via telemedicine. This act does provide a definition for the practice of telemedicine, which would allow prescribing to take place even if no physical encounter conditions were met. So what are the benefits of providing services via telehealth? It can, of course, be convenient for providers because now in New York State, telehealth can be delivered according to the Department of Health from their home or private office, granted they have a secure HIPAA-compliant connection. Most importantly is that access. I'm always going to go back to convenience and access for patients, especially for those who live in rural areas or have limited mobility. Improved quality of care is also a benefit to utilizing telehealth. There was a recent study published in the American Journal of Managed Care that showed that a behavioral telehealth management program had a positive impact on cardiac patients' care, reduced the number of admissions and readmissions, and lowered treatment costs. Researchers looked at 400 patients with cardiac conditions and split them into two groups, one that participated in a behavioral health telehealth program and one that did not. Cardiovascular disease can take an emotional toll on patients and lead to behavioral health issues like depression or anxiety, which can negatively impact their recovery. The program consisted of 16 phone or video sessions where providers and social workers provided patients with psychological support and gauged their progress in mental health. The researchers then tracked the hospital admissions and length of stays for 6 months after that first consultation and compared those numbers with the control group. The study results confirmed that the telehealth program had a positive effect on patients' health and hospital operations. Patients who went through this program scored lower for depression, anxiety, and stress over the other group. Additionally, over the 6-month period, patients who participated had 38% fewer hospital admissions and 31% fewer readmissions. Even when patients were admitted to the hospital, program participants were less likely to be admitted more than once, and on average spent 63% fewer days in inpatient care. The program also bolstered patients' engagement with their care, which is an important criteria for providers trying to earn meaningful use incentives. So, last frequently asked question here, where can patients access telehealth or telemedicine? So patients should, of course, be speaking with their providers or hospital about these services and their availability. Appointments can be scheduled the same as face-to-face visits. So what can providers do? Providers can market telehealth in their own way, so can the practices that they work in. Whether that's through a simple pamphlet or brochure, a flyer in the waiting room, to actually offering it during their next in-person visit. If you are implementing a telehealth program, let patients know that this is a new and exciting service being offered, and you want them to be one of the first patients to try it. In addition, patients can access telehealth from their smartphone. If you think back to the beginning of this presentation, I spoke about mobile health. Many private insurers now offer 24/7 access to a healthcare professional via a smartphone. I personally, myself, used one of these smartphone apps several weeks ago and found it to be extremely convenient. And the copay was the same as if I went to my provider in person. And I was able to get my issue handled, a prescription sent to my local pharmacy. So I find that to be a very convenient way of accessing healthcare. So before we move on to our Mythbusters section, I'm going to do a second poll. This second poll is going to ask you what the status of telehealth or telemedicine is in your organization. So we'll take about a minute to have everybody take a look at that. We'll take about a few more seconds. All right, I'm going to close the poll in 10 more seconds. Okay, so results are actually pleasantly surprising. Most of you have a telehealth program for over 1 year, which is really exciting. And then, of course, the second highest is that we don't have a program yet, but are interested in exploring that further. And of course, that's what AHI and myself are here for. So moving on, we're now going to go into our Mythbusters section. So our first myth, telehealth is just too complex. So telehealth is really no different than any other remote communication tool that most providers or individuals, period, use on the daily. There are, of course, additional factors to consider, such as security and privacy. But at its core, telehealth and telemedicine are just an application of technology most of us are already using. Myth, providers must conduct a physical exam to properly diagnose a patient. So I will give a disclaimer, I'm not a provider and I'm not trying to say that providers have to do this, but for certain low acuity conditions, a patient's medical history and reported symptoms could be sufficient enough for a proper diagnosis. Of course, telehealth will never replace in-person care, but it is a great tool in the toolkit. In its early days, telemedicine was primarily a phone-based interaction between patient and provider, but technology has evolved and video telehealth can create a more intimate interaction between patient and provider. Keep in mind too that the spoke site where the patient sits is often equipped with a blood pressure cuff or a thermometer, and that the spoke site nurse or medical assistant can take any necessary vitals that the hub site provider needs. Of course, I'll keep going back to convenience and access. A great example is New York Presbyterian recently implemented a virtual visit service called Telehealth Express Care for their emergency room at the Weill Cornell Medical Center. This Express Care service reduced ER wait times from 2.5 hours down to having low acuity patients in and out in 35 to 40 minutes, and that's from arrival to discharge. In terms of quality and consistency, every patient, no matter the location in this express care service, received the same screening and triage. A triage nurse asks for the chief complaint and takes the vitals, and then the patients are sent to rooms where they have video visits with ER physicians who are elsewhere in the health system. Myth: telehealth puts providers at risk for malpractice lawsuits. As a general rule, malpractice carriers have now built-in telehealth protection to their policies, and by allowing the patient more frequent communication with their provider through this method, problems can often be addressed sooner. Some malpractice insurance will cover services provided via telehealth, but not all carriers operate in this same fashion. Additional coverage may need to be purchased, and providers should ascertain that they are adequately covered by their carrier or seek out another if necessary. Also keep in mind, if you're practicing in multiple states, malpractice carriers may not extend their coverage to other states due to various reasons such as lack of ceilings to malpractice awards. A provider's current carrier may not be able or willing to provide coverage across state lines, so that's something to keep in mind as well. Myth: telehealth utilizes too many IT resources. This is an understandable concern, and you certainly need to have your IT staff or team involved in this process, but they don't need to be a main component. The IT component is not as critical as the medical staff training and engagement, or the billing staff, front office staff. Everybody plays a role in this. And to be honest, most telehealth software or hardware companies provide IT or implementation service professionals who have years of experience in this field and can step in and manage the process for you and your organization. Lastly, most of these platforms have very simple, easy to use interfaces. Myth: it's best to wait until telehealth is reimbursed before implementing it. I think this is the most important myth. As we move towards value-based contracts and bundled payments, telehealth will become more important to deploy in organizations that are engaged in these contracts and seeking additional reimbursement. Under the fee-for-service system, investing in systems to reduce waiting time is an example of that I have to spend money to lose money dynamic. And few, if any, healthcare executives would deliberately allow patients to wait longer and become sicker in order to enhance revenue. But when resources are scarce, it's hard to argue for projects with an often negative return on investment, such as telehealth. So why are health systems deciding to deploy this anyway? One reason is the fight for market share. When the Cleveland Clinic started offering same-day appointments in 2011, other providers quickly realized that they risked losing patients if they didn't offer more timely access. Another reason is the spread of value-based payment models that reward providers who drive care to more efficient settings, making it more important to provide that timely access. Value-based payment models also create possibilities for providing specialist access through innovative channels. Some examples are Geisinger, Kaiser Permanente, and Group Health. These health systems have leveraged platforms such as secure messaging, telephone visits, telemedicine visits, all to provide more timely, efficient, and convenient care. This virtual medicine has generally led to improvements in the patient experience, the clinician experience, the quality of care, and reduction of unnecessary inpatient and ED utilization, which is a huge component of DSRIP, if not the main initiative of DSRIP, so keep this in mind. Lastly, according to a survey done last year by American Well, which is one of the nation's largest telemedicine service companies, if a patient's primary care provider does not offer telehealth, 80% of respondents stated they would switch to one that offered it. This willing 20th to switch rises to 26% in the 18 to 34-year-old cohort and up to 34% for parents with children under the age of 18. Myth: telehealth costs too much. So telehealth can cost a lot if you let it, but it need not be expensive. If you are a practice offering virtual visits for a routine checkup, behavioral health follow-up, It can be as simple as using your own computer, which likely already has a web camera, and then engaging in a secure software platform, which can be very inexpensive. Of course, depending on the specialty you decide to provide or access, that cost can go up. Thinking back to where I spoke about reduced wait times at New York Presbyterian, Geisinger Health System recently discovered that longer waits for specialist appointments generally led to higher costs. Among patients awaiting specialist appointments, the 30-day rate of ED or inpatient utilization was 8.7 times the rate among patients who weren't awaiting appointments, presumably indicating that these patients were sick and at high risk for complications. So when Geisinger controlled for other variables such as demographics or clinical conditions, they found that patients who waited longer until their specialty appointment generally had a higher rate of ED utilization during a 30-day period. Geisinger decided to then focus strongly on a tele-ICU program, arguably one of the most expensive areas of healthcare. Implementing tele-ICU technology allowed them to cut readmission rates by 44%. They also found that by using telemonitoring technology for their heart failure patients, they were able to save $216 per patient per month, and those savings can add up significantly. Okay, our last myth, patients won't use it. So according to the same previously referenced American Wealth Survey, the market value of telehealth is expected to be over $36 billion in the next 2 to 3 years, attracting 7 million patient users by the end of this year alone. 65% of consumers are willing to see a provider over video, which is a gradually increasing trend. 60% of those same consumers would be willing to have online video visits for regular check-ins to manage a chronic condition. And that percentage was similar across all age cohorts. So what is driving this increase in consumer willingness to see a doctor over video? One factor may be the length of time it typically takes to have a brick and mortar doctor's visit. For consumers in a U.S. city, it takes an average of 18.4 days from the time a patient makes the appointment to get in to see the doctor. Once the patient has that appointment, the average in-office visit takes 121 minutes, with 20 of those minutes spent seeing the doctor and the remaining 101 minutes spent traveling to and from the office and sitting in the waiting room. Compare those times to a video visit. Southwest Medical Associates of Las Vegas found that patients using video visits in their system spent approximately 5 minutes waiting and 8 to 10 minutes seeing the doctor. So think of that difference right there. Video visits offer a huge convenience to patients and often at the same or lower copay cost, as health plans increasingly cover telehealth as a benefit for their members. Keep in mind that those smartphone-based apps are right now only available through most private insurances. I don't believe Medicaid or Medicare has this as a service yet. So that wraps up today's portion of what I'm going to be talking about. I will open it up now for questions. I would welcome any questions. There have been several that have come through. So please submit your questions through the Q&A box, and I will begin working through them. The first question was that remote patient monitoring is covered by Medicare. We will be discussing this a little more intensely at the next webinar, but I do know that it is very limited in coverage, and you know, that was more just like a blanket statement. I know that Medicare does not cover that very well. And we will give a few minutes for additional questions to come through. Let me see if anybody's raised their hand. Well, I'm not seeing a whole lot. Oh, RPM services are covered by Medicaid. Yes, Joe, remote patient monitoring services are covered by Medicaid. We will be talking more about this again at the next webinar. They, I believe, reimburse up to $32 per month per patient, and they are currently reassessing those fees for the next Medicaid update. We have a question from Karen Caminiti. What are some approved sites for telehealth? Again, I apologize, that will be discussed more at the next webinar. But to answer your question right now, it depends on if you're looking at the Department of Health regulations, the Office of Mental Health Regulations, Medicare. So it really depends. It's hard to answer that in a blanket statement. The next webinar is going to be on February 13th, which is 2 weeks from today at the same time, 1 p.m. And I'll wait about 1 more minute for people to submit any last questions. Okay, so we have a question about providers being reimbursed since a home is now originating site. Does that mean providers only conducting visits from their homes or visiting nurses? So what I mean by that is the Department of Health, so I believe this is specific to Medicaid fee-for-service and Article 28 facilities. Providers' home or their private office is an eligible hub site, not patient site. So keep that in mind. Providers can see patients from their private practice or their home office, provided that it is secure. The Department of Health has recently come out with some expanding originating site definitions, but those won't be in effect for several months, and we'll talk about that on the next webinar. We have a question from Olivia McMullen. How does telehealth accommodate patients diagnosed with an intellectual and/or developmental mental disability? That is a fantastic question. The New York State Office for Persons with Developmental Disabilities currently doesn't have any telehealth regulations. So to my knowledge, there are not too many facilities such as an ARC taking advantage of this service. So for right now, you can certainly accommodate those patients. Family members or friends or support staff are allowed in the room with the patient. The video visits are never recorded. And, if the patient wanted the nurse or medical assistant to be in there while they're talking with the patient provider through the screen, that's allowed as well. So they can certainly be accommodated and utilize this just like anyone else. Bonnie Sloma asked about articles substantiating the use of telehealth. I can certainly reference some of the research that I did for this presentation and send that to you, Bonnie. So yes, to answer your question. Question from Christine Duffy, is telehealth being used in summer camps? Now that is a unique way to use telehealth. To my knowledge, I have not seen that yet done, but telehealth can be used, it can be used in non-conventional ways. So I work with several school systems that are implementing telehealth to keep children in the school, utilizing it in correctional facilities, for inmates, for behavioral health. So I certainly don't see why it couldn't be used in a summer camp. The only condition there is that a summer camp is not a valid originating site by most regulatory bodies, so it more than likely wouldn't be reimbursable. So that's the only caveat with that. Karen Caminiti asked, are doctors the only practitioners that can utilize telehealth? Definitely not the case. Again, it depends on which agency you're looking at. So if you're looking at the Department of Health versus the Office of Mental Health versus OASAS, they have different definitions of eligible providers. We will be talking more about that at the February 13th webinar. But mid-level providers, genetic counselors, social workers, asthma and diabetes counselors, dentists, physical therapists are all eligible providers in New York State. We'll see if some more questions come in. Again, please submit your questions through the Q&A box. I see a few hands raised, so if you can just type your question into the Q&A box, I would appreciate it. All right, well, thank you everyone for all the questions. My email is right on this slide, so if anybody has additional great questions, feel free to shoot me an email. I have a lot of resources at my fingertips and can probably answer your question. And if I don't have the answer, I'll find it for you. So that will be it for today's webinar. I'm going to give you guys 20 minutes back of your day, so you're welcome. Again, this will be archived and the recording will be up later this week. Thank you for joining me, and I hope to see all of you on February 13th. Thank you.